Welcome back to the deep dive. We're here again to take things that feel, complicated, maybe overwhelming, even confusing, and really break them down, giving you a structured, actionable roadmap. Everything we talk about comes directly from the source material you need.
That's right. And our mission today, it's a big one. It's about managing a transition that, frankly, can be terrifying for families. We're moving from Chapter 4's focus on that really sensitive initial conversation about early cognitive signs.
Yeah, that was heavy stuff.
It was. And now we're diving into Chapter 5, which is all about the next inevitable step, engaging with the medical system. It's about getting into the operational phase.
Okay, the operational phase. And I think for pretty much every caregiver listening, that's where the feeling of being completely overwhelmed just skyrockets. You're already dealing with so much emotionally, and then bam, appointments, referrals, medical jargon, doctors who only have like 10 minutes.
Exactly. It's a huge hurdle.
Yeah.
The source material we're looking at actually calls the medical system, especially under these circumstances, a maze.
A maze, yeah. That sounds about right.
And so our specific mission today is to pull out the 5 absolutely crucial insights from this chapter. We really want to give you the practical step-by-step actions you need to take that anxiety about the first doctor's visit and turn it into something productive, something confident.
So you walk in prepared, organized, and feeling like you'll actually be heard.
Precisely. Because if you, as the caregiver, have that fear, that deep-seated worry about being unprepared or wasting the doctor's time or maybe just getting brushed off.
Which happens.
It absolutely does. That fear becomes this massive psychological barrier. It stops people from seeking help early. So this chapter, Chapter 5, it promises to replace that fear with a concrete strategy. Okay, let's really unpack this then. What's the core foundation here? What's the central argument Chapter 5 is making right from the get-go? What's the main pain point it's trying to solve for you?
Okay, the core pain point is laid out very clearly right in the summary for this step, Step 5. It basically says the single biggest reason so many caregivers delay getting professional medical help. It's that feeling of just complete confusion, feeling totally unprepared.
Yeah, not knowing where to even start.
Exactly. They see the whole healthcare system as this like impenetrable maze, and that anxiety, that sort of general, I don't know what to do feeling, it leads straight to procrastination, putting it off. And that costs incredibly valuable time, especially with cognitive decline. Oh, I can absolutely see that. I mean, you're already grappling with the emotional weight of potentially Alzheimer's or dementia, which is just crushing on its own. Then you pile on trying to figure out scheduling, insurance, different doctors, what tests mean. It just feels like too much.
It really is a massive roadblock for so many families. And the central argument, the real foundation of this entire chapter, is specifically designed to dismantle that roadblock. And the argument is essentially this. You do not need a medical degree to be an effective advocate for your loved one.
Okay, that's important. Say that again.
You don't need medical training. Your power as the caregiver lies in 3 actually pretty simple things: preparation, organization, and documentation. That's it. You're not going into that appointment expected to diagnose anything.
Right.
Your job is to go in and provide clear, actionable data based on your observations.
So it's really about a shift in perspective, isn't it?
Yeah.
You stop thinking of yourself as just, the worried family member and start seeing yourself as the primary data collector, the evidence coordinator.
Precisely. That's a great way to put it. You're shifting your role, your agency. You move from feeling powerless in the face of this scary potential diagnosis to becoming the organized force that actually secures the necessary next steps from the medical team.
Okay.
And the goal of the chapter, it's stated very explicitly, it's to empower caregivers, to help you use organized observations, preparing focused questions, and choosing the right doctors, using those tools to transform that initial overwhelming confusion into real clarity, into forward momentum.
Okay, so that's the goal. But what are the stakes here? What happens if we, don't get this right? Or if we just keep putting off that appointment because it feels too hard?
Well, the stakes are actually enormous. The source material really emphasizes this point, getting that early medical consultation and this is the key part, when it's properly grounded in that symptom journal, those objective caregiver notes we talked about in our last deep dive.
The ones where you're tracking specific behaviors and dates.
Exactly. When the consultation is based on that kind of evidence, it significantly increases the chances of getting timely support, getting the right interventions, and honestly, reducing long-term stress for everyone involved, both the person with the symptoms and the caregiver.
That makes sense.
Think about it. If you walk into a doctor's office armed with objective, documented evidence patterns, dates, specific examples, Even a rushed or maybe slightly skeptical doctor can't easily dismiss your concerns. They can't just write it off as, general anxiety or exaggeration.
That's such a critical point. We all know doctors are short on time. They're trained to look for patterns. If you just go in saying, I'm worried, they've got to start digging from square one, right?
Right.
But if you walk in with, say, 3 months of documented patterns, here's what I've seen, here's how often, here's when it started, you're essentially handing them the clinical key. You're fast-tracking the process.
You absolutely are. You're enabling that crucial partnership. The doctor brings the clinical expertise, the diagnostic knowledge. But you, the caregiver, you bring the day-to-day, the longitudinal evidence, the real-world context. That operational partnership is really the foundational message of Chapter 5.
Okay, this is all making a lot of sense conceptually, but, abstract principles are one thing. They might feel reassuring now, but they don't always help much when you're actually sitting in that waiting room, heart pounding.
True.
So here's where it gets really important for you listening. What compelling, real-world story or piece of evidence does the author use to hook the reader right away? To prove that this whole preparation thing actually works in practice.
Yeah, the author handles this really effectively. They don't just talk theory. They immediately pivot to a very powerful, very relatable case study. It's the story of a woman named Rachel.
Okay, Rachel, let's dive deep into her experience. Tell us about her. What was her situation? What first made her think, okay, something's not right here? What was the trigger?
So, Rachel is introduced as a 49-year-old teacher. She's helping care for her father. And her initial trigger, the thing that sparked her action, it wasn't some huge dramatic memory lapse like forgetting her name or something, which is often what we sort of fear or expect.
Right.
Instead, it was something much more subtle. It was a recurring pattern that pointed towards a specific issue with executive function. She noticed her father was repeatedly missing bill payments. Things were getting overdue.
Ah, yes. That is such a classic early sign, but it's one that gets missed or explained away so often, isn't it? People think, oh, Dad's just getting a bit careless or he's stressed. It's not always about forgetting ancient history. It's often about difficulty with planning, organizing, managing finances, exercising judgment.
Precisely. And the source uses this specific example, the missed bills, to illustrate that the warning signs are frequently rooted in these kinds of organizational difficulties, not just pure memory recall problems. And Rachel's response to noticing this pattern, it's presented as the perfect example of the playbook, this chapter's advice, in action. She didn't panic. She didn't just worry. She took concrete, strategic steps. And her preparation involved 3 key actions that we really need to break down for the listener.
Okay, let's hear them. Step 1 for Rachel.
Step 1, she was diligent. She kept that symptom journal we talked about. She logged specific instances, missed bill due dates, maybe confusion about accounts with dates, times, any relevant context. Just like the playbook recommends. She treated these observations almost like forensic evidence.
Okay, so disciplined data collection, got it. What's step 2? Because you can have pages of notes, but that doesn't automatically help the doctor.
Exactly. And step 2 is where, as you put it earlier, the magic happens. This is where you turn raw data into usable intelligence for a busy doctor. Rachel condensed those notes, which I imagine were probably messy, maybe emotional at times.
You're writing things down when you're worried.
Right. She condensed all that into a concise, short summary. The source is very specific here. It emphasizes a 1-page maximum.
1 page. That's tough.
It is,
Thanks,
but it's
Brad.
crucial. And on that 1 page, she highlighted only the top 3 to 5 most concerning, most recurring patterns, like the bill paying issue. This single act does 2 things. It shows profound respect for the doctor's limited time, and it gives them an immediate, scannable, clinical summary of the core problems.
So she's essentially acting as a filter. She's cutting out the noise, maybe her own frustration or anecdotes from years ago, and she's leaving only the objective, documented data points that show a recent pattern.
Exactly that. Filtering is key.
Yeah.
And then step 3. She prepared specific questions. But crucially, they were non-leading questions. They were designed to guide the doctor towards the right diagnostic path rather than sort of demanding a specific diagnosis up front.
Okay, examples are good here. What kind of questions did she prepare?
The source gives these brilliant examples. Things like, could these changes we've observed be related to normal aging or maybe stress, or could it be something else entirely?
Yeah. Open-ended.
Very. And another one. Based on this documented pattern of missed payments and maybe some confusion, what tests would actually help clarify the underlying cause?
Okay, I really want to pause on those questions for a second.
Yeah.
Because they are so much smarter, so much more effective than the kind of leading question. that I think many of us would instinctively jump to, right? Like marching in and asking, do you think Dad has Alzheimer's?
Absolutely. That kind of question can sometimes put a doctor on the defensive, or it prematurely narrows the focus. Rachel's questions, they do the opposite. They invite a professional, open-minded response. They open the door for what doctors call differential diagnosis.
Oh, jeez.
It's the process they use to systematically rule different possible causes in or out. Is it medication? Is it depression? Is it vitamin deficiency? Is it mild cognitive impairment? Or is it dementia? Her questions show the doctor that she's organized, she's objective, and she's ready to follow their expert guidance based on evidence.
Okay, so discipline prep, journal, one-page summary, smart questions. What was the result for Rachel and her dad? Did it work?
It worked immediately and profoundly. The source states that Rachel's careful organization successfully guided the doctor. It prompted them to order the specific cognitive tests that were needed in this case. And those tests, they quickly confirmed that her father was indeed in the early stages of Alzheimer's disease.
Wow. So she got a diagnosis. But what about Rachel herself? We know the clinical outcome for her dad, but what was the emotional payoff for her, having gone through that process so prepared?
That's the crucial part for you listening. Yes, she left that appointment with a difficult diagnosis for her father, but she left feeling confident. She felt supported by the medical team. She didn't feel confused or dismissed or distraught in the way she might have if she'd gone in unprepared.
That's huge.
It's absolutely huge. The chapter explicitly says Rachel's method turned an intimidating appointment into a productive, reassuring step forward. This anecdote isn't just a story. It's immediate proof that the practical advice in this chapter works. The emotional payoff isn't about finding a cure instantly, but about gaining clarity. And clarity, even if the news is tough, dramatically reduces anxiety and empowers you for the next steps.
That is such a powerful lesson. It's like the preparation itself acts as an emotional buffer. It protects you a bit from the kind of cold clinical reality of the medical setting because you feel like you did your part effectively.
Well said. It gives you a sense of control in a situation that feels very out of control.
Okay, so the chapter uses Rachel's story to prove the methodology works.
Yeah.
But looking forward, what does this chapter promise you, the reader, for the rest of the book? What key questions does it raise that we can expect to get answers to later on?
Right. The chapter makes a really critical twofold promise here. It offers both immediate relief and sets up the future direction. The immediate promise is all about tackling the caregiver's current anxiety head on. It essentially says, you will be able to enter medical visits with confidence and leave with clarity.
Confidence and clarity. Nice.
And it keeps reiterating that the goal of this specific step, Chapter 5, is getting reliable information, getting a definitive set of next steps from the doctor. It consciously dials down the pressure by saying the goal right now is not necessarily getting an immediate, final, perfect diagnosis in that first visit.
Okay, so clarity over certainty, at least initially. That does reduce the pressure quite a bit, doesn't it? You don't feel like you failed if you don't walk out with a label right away.
Exactly. It manages expectations realistically. But then there's the forward promise, and this is where the whole guide pivots towards the long-term journey of caregiving. Because once you've navigated that initial diagnosis or clarification phase, the next overwhelming question that hits you is, okay, now what? What do we actually do day to day to manage this, to support my loved one?
Yeah, the what now question is huge.
It's huge. And this chapter skillfully sets up the answer by teeing up Chapter 6. The title is revealing: Enhancing Daily Life with Lifestyle Tweaks and Support-Building Routines that Protect and Uplift. So the guide expertly shifts your focus. It moves you from the stress and anxiety of the clinical diagnosis process towards practical, immediate supportive actions you can take.
That transition feels vital because I imagine after getting a diagnosis, a caregiver might feel completely paralyzed. Like, okay, we know what it is, but I have no idea how to help now.
Yeah.
Knowing there's a plan for that next is reassuring.
Absolutely. And this forward promise, this bridge to Chapter 6, it isn't just vague reassurance. It's backed up by very specific deliverables mentioned in Chapter 5. The source calls them the confidence tools for post-visit follow-up.
Confidence tools, okay.
These are designed to make sure that the momentum, the clarity you gained in the appointment, doesn't just evaporate the minute you walk out the clinic door, which can easily happen when you're stressed or overwhelmed.
Okay, tell us more about these follow-up tools. Why are they so structured? What are they?
The structure is there specifically to guarantee sustained confidence and, importantly, follow through. Things don't fall through the cracks. So the tools are, first, you need to summarize the doctor's notes. Capture the diagnosis, if given, and list out the agreed-upon next steps, tests, referrals, medications. And critically, you need to do this within 24 hours of the appointment.
Within 24 hours. Why so quickly?
Because medical details are notoriously slippery. You forget things, your emotional filter kicks in and maybe distorts what you heard. The source stresses that 24-hour window because you need to capture the clinical nuance, the specific instructions, while it's still fresh in your mind, before memory fades or emotions cloud the details.
So it's not just about keeping a record. It's actually a cognitive task in itself, forcing yourself to process and consolidate the information right away.
Precisely. It makes you actively engage with what was said. Okay, second tool, sharing those updates. You take that consolidated summary, the key points, the plan, ideally without all the raw emotion, and you share it with key family members.
Getting everyone on the same page.
Exactly. This helps build a shared understanding, distributes the load a bit, and importantly prevents situations where different family members have conflicting information or maybe fall back into denial because they weren't at the appointment. Alignment is key.
That avoids so much potential conflict down the line.
It really does. And the third tool is very practical. Setting immediate reminders. Put those necessary referrals, the dates you expect test results, or the timing for follow-up visits into your calendar, your phone, whatever system you use, right away. Don't just think, oh, I'll remember to call for that neurology appointment.
Right, because you probably won't when you're juggling everything else.
You won't. This step transitions the clinical advice you received into a concrete project management task. It ensures no critical step gets missed simply due to exhaustion, overwhelm, or forgetfulness.
You know, what's really fascinating about the whole structure of Chapter 5, listening to this, is that it seems to be selling you on the idea that the confusion, the feeling of being lost in the medical system, is not necessarily inherent to the system itself, even though it is complex. It suggests that confusion often stems from a poor process on the part of the unprepared caregiver.
That's a very insightful way to look at it.
If you follow this structured process, the journal, the summary, the questions, the follow-up, you gain clarity, regardless of the system's complexities.
I think that's absolutely the underlying message. The ultimate goal is to replace that kind of paralyzing, generalized anxiety, I can't handle the medical system, with a series of specific, measurable, achievable, relevant, time-bound, basically manageable tasks. It puts you back in the driver's seat for your part of the process.
Okay, this brings us beautifully to the operational heart of this deep dive, the absolute core. If you, listening right now, could only remember one single thing from Chapter 5 after we're done, what should that most important takeaway be? The ultimate key that kind of synthesizes all this advice.
Okay, the ultimate synthesis. It's highlighted really effectively in the reflection section that follows Rachel's case study in the source. It boils down to this definitive shift in mindset, moving away from feeling powerless and towards taking active, organized agency. The key mantra, the single most important takeaway is this. You don't have to control the system, you just need the right tools to guide your loved one through it.
Okay, you don't have to control the system. You just need the right tools to guide your loved one through it. That distinction feels profound. It gives you, the caregiver, permission to stop feeling like you need to suddenly understand neurology or hospital administration.
Exactly.
Instead, your focus narrows entirely to being that organized, precise advocate using the tools provided.
It relieves you of that impossible burden of needing to know everything, of needing to be the expert. You don't. And those right tools, that's not just a vague phrase. The chapter defines them very clearly. They make up the core of the practical toolkit, pulled directly from the action checklist details in the playbook. This is the actionable how-to part that makes the chapter so incredibly useful.
All right. Let's dedicate some serious time now to breaking down that toolkit piece by piece.
Yeah.
Because this is the tangible value, the stuff you can actually use tomorrow. What are the core components, let's say the 4 main pillars of this toolkit, and how do we execute each one flawlessly based on the chapter's advice?
Okay, pillar number 1. This is absolutely non-negotiable. Organize your symptom journal. We've touched on this, but let's get specific. This is where you transform potentially pages and pages of scattered notes, dates, worries, observations into that crucial one-page professional briefing document we discussed with Rachel.
The one-pager.
The one-pager. The chapter's really specific about the process. Condense all relevant entries into a concise one-page summary, and on that page, you highlight only the top 3 to 5 most significant recurring signs or patterns you've observed recently.
Okay, but here's the practical challenge. How does a caregiver actually decide what makes the cut, what to keep and what to leave out? If you've been worried for a year, you could have dozens of examples. How do you get that down to one page without losing important info?
That's a great question, and it's a real hurdle. The source material offers guidance here. It recommends focusing on clustering symptoms rather than just listing incidents chronologically.
Clustering, how does that work?
Instead of saying Jan 5th, Dad forgot where he put his keys, Jan 12th, Dad forgot his wallet, Jan 19th, Dad couldn't find his glasses. If you cluster that pattern, you'd write something like, difficulty tracking personal items, frequently misplaces keys, wallet, glasses, 3-4 times a week over the past 4 months, often becomes agitated when searching. See the difference?
Yeah, it shifts from isolated events to a demonstrable pattern of behavior with frequency and duration.
Exactly. You have to be ruthless in omitting things like your own emotional reactions in the summary. Save those for your own support system. Caregiver theories, I think it started when. Or long, rambling narratives about events that happened years ago. The focus must be on observable patterns within, say, the last 6 months to a year maximum.
So, for instance, instead of writing, Dad got really confused and upset last Tuesday during dinner, you could cluster it, maybe.
You'd cluster it. Maybe under a heading like increased confusion in familiar settings. You'd note episodes of confusion during routine activities, very dinner time, watching TV, occurring 2-3 times per week for the last 2 months. Examples include brief, specific example like difficulty following conversation or repeatedly asking what we're eating, often accompanied by frustration. It's about frequency, context, specific cognitive task, and time frame.
That single, tightly organized page essentially does the doctor's initial filtering work for them, doesn't it? It reduces their cognitive load massively.
By 90%, easily. It allows them to skip the tell me what's been happening fishing expedition and jump straight into targeted questions and assessment based on the patterns you've already identified. Okay, pillar number 2, draft specific questions.
Right, the non-leading ones.
The non-leading targeted questions. We gave a couple of Rachel's examples earlier, but let's broaden this out for the listener. The source implies you can categorize these questions for maximum effect to make sure you cover all bases.
Okay, categories are helpful. What are they?
Okay, think of maybe 4 key categories. Category 1, clarification and differentiation. These questions directly address the fear of misdiagnosis or jumping to conclusions. They force the doctor to consider alternatives. So questions like, we've noticed these specific changes referencing your summary. Could these be related to normal aging? Or could stress, depression, medication side effects, or perhaps a vitamin deficiency be playing a role here? Or is it likely something else?
Okay, forces the differential diagnosis. Good. Category 2.
Category 2, diagnostic next steps. These questions push for concrete action. You're asking, okay, based on the patterns we've documented in this summary, what do you recommend as the best next step to get more clarity? Would that be specialized blood tests, a brain scan like a CT or MRI? Or should we be looking at formal neurocognitive testing?
Okay, asking for the plan. What's category 3?
Category 3 is about immediate lifestyle adjustments. This is crucial because it gives you, the caregiver, and your loved one something proactive to do right now, while you might be waiting for test results or specialist appointments. It combats helplessness. Ask, are there any non-medical things we should be doing right now? Any specific lifestyle adjustments may be related to diet, exercise, sleep, or even specific types of cognitive engagement or social activities that you'd recommend we start implementing today.
I really appreciate that third category. It empowers you to take some action immediately, reducing that awful feeling of just waiting passively for bad news or complex tests.
Absolutely. It keeps the focus on well-being, not just diagnosis. And the final category, category 4, should be about future planning and referrals. Ask if these memory or cognitive concerns continue, or if the initial tests are inconclusive, who is the right type of specialist for us to see next? And what criteria should we use to choose a good neurologist or geriatrician in our area?
That flows perfectly into the third pillar of the toolkit, which you just mentioned. Research specialists. This seems critical because not all doctors are equally experienced in this area. What advice does the chapter give about finding the right referral?
Right. This is super important. The default is usually to start with your primary care physician, your PCP or GP, and that's generally the right first step. They're the gatekeepers. However, the chapter strongly advises that if memory or cognitive issues are the central concern, you need to be prepared to research and potentially push for referrals to specialized doctors. Specifically, it mentions neurologists and geriatricians.
Okay, can we quickly clarify the difference between those two for the listener? Because that distinction often gets blurry for people.
Sure. It's a common point of confusion. Think of it this way. A neurologist is a specialist focused on the brain itself, the physical structure, the nervous system. They diagnose and treat diseases of the brain, like Alzheimer's disease, Parkinson's, stroke, epilepsy, MS-CAP. Their primary role is often confirming the specific neurological disease.
Okay, disease-focused. And a geriatrician.
A geriatrician is an internal medicine doctor, an internist, who has specialized training in the unique and often complex health needs of older adults. They're experts in managing multiple chronic conditions, comorbidities simultaneously, including things like frailty, falls, medication management, and cognitive decline within the broader context of aging. They often focus more on overall functionality, quality of life, and care coordination for an older person.
So ideally, if a diagnosis like Alzheimer's is confirmed, you might end up working with both. The neurologist for the specific disease management and the geriatrician for the overall holistic care.
That's often the ideal scenario, yes. The neurologist confirms and treats the Alzheimer's, the geriatrician helps manage everything else that comes with aging and the impact of the dementia on daily life and other health conditions. But the key point from Chapter 5 is, don't just passively accept the first referral name you're given, especially if it's not to one of these specialists. You need to do a little homework.
Right. But vetting doctors can feel awkward. You don't want to offend the referring doctor or the specialist office. How does the chapter suggest you vet them professionally?
It offers a very practical, non-confrontational approach. You don't call the specialist's office and ask, is Dr. Smith good with dementia? That won't work.
No.
Instead, you vet the practice itself. You call the office, ask to speak to the office manager or the scheduling coordinator, and you ask specific objective questions about their routine. Questions like, I'm looking for a doctor to evaluate potential memory issues. Could you tell me roughly what percentage of Dr. Smith's practice is focused on cognitive assessments, dementia care, or memory problems?
Okay. Asking about their focus area.
Exactly. And another good one. How frequently does Dr. Smith typically perform specialized cognitive screening tests, like the MoCA Montreal Cognitive Assessment or the SLN's St. Louis University Mental Status Exam as part of their routine evaluations?
Asking about the tools they use regularly.
Right. These questions help you gauge if evaluating cognitive issues is a core routine part of their daily work or something they only do occasionally. If the office manager says, oh, Dr. Smith mostly sees patients for headaches and back pain, maybe a few memory consults a month, you probably need a more specialized referral. But if they say, oh, yes, evaluating memory and cognitive health is a major focus of our practice, Dr. Smith does several cognitive assessments every week, then you've found a potentially good fit.
That's actually a very clever, very professional way to gather the intel you need without putting anyone on the spot. You're asking about volume and routine procedures, not directly questioning their competence.
Precisely. It's the difference between asking, are you qualified, and asking, is this what you do all day, every day? Very different questions.
Okay, makes sense. And that brings us to the fourth and final pillar of the toolkit, logistics prep. These are the practical, maybe seemingly small details that you absolutely cannot overlook on the day of the appointment. What are they?
Right, the logistics. Get these wrong, and even the best preparation can get derailed. The chapter emphasizes bringing 3 physical items with you every single time.
Your concise one-page symptom summary.
Your checklist of specific questions.
And this one is absolutely critical, the current, complete, up-to-date medication list.
Okay, the medication list. Why is that one so non-negotiable, especially in the context of a cognitive assessment?
It's incredibly critical because a surprising number of medications or combinations of medications or even incorrect dosages can cause side effects that perfectly mimic the symptoms of early dementia. We're talking confusion, lethargy, memory problems, dizziness, changes in alertness.
Wow.
If the doctor doesn't have the full picture of every single thing your loved one is take, prescriptions, over-the-counter drugs, vitamins, supplements, everything, they might start down a complex neurological investigation path when the actual root cause is pharmaceutical. It's a common issue, especially in older adults who are often on multiple medications managed by different doctors.
It seems like the simplest thing to bring, yet probably one of the easiest things to forget or get wrong if you're flustered.
It absolutely is. Make sure it includes dosages and how often they take each thing. Don't just list the drug names. And the final piece of logistics prep is about the approach to the appointment itself, particularly regarding your presence as the caregiver.
How you frame it for your loved one.
Exactly. Attending a memory assessment can feel embarrassing or threatening for the person being evaluated. The chapter advises framing your presence positively as a supportive partnership. Say something like, hey, Dad, I'll come with you to the appointment. That way, between the two of us, we can make sure we remember everything the doctor says and don't miss any important details. We'll be a team.
Uh, so you frame it as we, as a tool for shared success and accurate recall, rather than I need to come because you're forgetting things. It reduces that feeling of being monitored or judged.
Precisely. It fosters collaboration rather than resistance. It makes your essential presence feel supportive, not intrusive.
Okay, that entire four-part toolkit, the organized journal summary, the specific question categories, the specialist research method, and the careful logistics prep when you lay it all out like that, it really does transform the abstract idea of being prepared into a concrete, step-by-step, executable plan. It feels much less daunting.
That's the goal, taking the unknown and making it manageable.
But I do have to circle back to the emotional side for a moment. We talked about the one-page summary being objective, filtering out emotion. How do you, as the caregiver, ensure that clinical summary still conveys the seriousness, the emotional weight of what you're experiencing without tipping over into, overly emotional language that might cause the doctor to tune out or dismiss it? That feels like a really fine line to walk.
That is a critical point of friction, absolutely. And it's one the chapter addresses more indirectly through its constant emphasis on agency and structure. The way you convey the emotional weight, the seriousness, isn't necessarily through using emotionally charged words in the summary. It's validated by the sheer effort and clarity of your organization.
The preparation itself speaks volumes.
Exactly. When you hand over that concise, well-organized, pattern-focused summary, you are non-verbally communicating to the doctor. This is not a fleeting worry. This is a consistent, documented problem that has concerned me enough to track it meticulously and present it professionally. This demands serious attention. The data carries the emotional weight implicitly.
So the time for venting the raw emotion is maybe before the appointment when you're writing the messy journal entries or talking to a friend. The appointment itself is for focused data delivery.
Precisely. The emotional relief, the validation you're seeking, often comes afterward when the doctor takes your organized concerns seriously and responds with a clear plan of action, acknowledging the patterns you presented. The organization is your pathway to that validation.
So essentially, the caregiver's difficult task is to translate what might be profound fear, frustration, and sadness into the highly distilled objective language of clinical observation. That's tough work.
It is undeniably tough, emotional, and cognitive work.
Yeah.
But the source argues, and Rachel's story illustrates, that it is the most effective path forward within the constraints of the medical system. The goal is getting the right help, and clear, organized information is the fastest, most reliable route to achieving that.
Okay, so pulling it all together now, let's do our initial critique and evaluation. Based on everything we've discussed from the source material, does Chapter 5 actually succeed in its overarching goal? And maybe just as importantly, is the writing style compelling enough to keep you, the reader, engaged and motivated through what is inherently a very difficult topic?
Right. Assessing it professionally, I would say Chapter 5 is extraordinarily successful. And the reason is its relentless, almost laser-like focus on actionability and structure. It absolutely meets its stated goal, which was turning that feeling of confusion and overwhelm into clarity and confidence.
How does it achieve that so effectively?
It does it by directly attacking the primary psychological barrier head-on, that feeling of being unprepared for the medical maze. It systematically moves the reader from that place of vague, paralyzing terror to a checklist of concrete, manageable, and highly specific tasks they can actually do. It demystifies the process.
Okay, so it succeeds on goal achievement, but what about the style? Is it compelling? Does it avoid just feeling like a dry instructional manual, given how checklist heavy it sounds?
It really manages to avoid that dryness, quite expertly, I think. There are a few reasons. First, it consistently prioritizes clarity over jargon. It uses straightforward, common language. The focus is on the logic of the checklist and the process, not on impressing you with dense medical terminology. It feels accessible.
Accessible is key here.
Definitely. Second, as we discussed, it brilliantly leverages relatability through the case study of Rachel. That story isn't just filler, it's a detailed anecdote that provides immediate, tangible proof that the recommended method works in the real world. It offers motivation based on demonstrated success, not just abstract theory.
The proof of concept is right there, baked into the narrative.
Exactly. And third, and I think this is perhaps the most powerful element, stylistically, it skillfully embeds empowerment throughout the chapter. It's not just telling you what to do, it's reinforcing your capability. The accompanying reflection questions mentioned in the playbook, they aren't just throwaway quiz questions. They're designed as self-assessment tools that actively reinforce your agency as a caregiver.
Can you give an example of one of those reflection questions?
Sure, the source mentions questions like, looking at my symptom journal summary, does it clearly describe patterns of behavior or is it just a list of incidents? Or, are the questions I've prepared truly open-ended ones that encourage explanation, or are they leading questions seeking a specific answer?
Ah, so they force you to critically evaluate your own preparation against the chapter's standards before you even step into the doctor's office.
Precisely. It effectively asks you to grade your own homework, ensuring you're not just passively hoping for the best, but actively taking steps to guide the consultation effectively.
So in essence, the chapter succeeds because it reframes the caregiver's role, not as a passive recipient of care, but as a precise, organized, proactive advocate.
That's the core of it. By defining that role so clearly and then providing the exact emotional framework,
Yeah.
permission to focus on process, not medical knowledge, and the practical tool set, the 4 pillars, to fulfill that role, Chapter 5 gives you everything you need to proceed with confidence. It equips you to ensure a productive outcome as possible.
Wow. Okay, this has been a really, really practical and I hope deeply helpful deep dive into what is, I think we can agree, arguably one of the most daunting operational steps any caregiver faces. So just to quickly recap the 5 core insights we've pulled out for you today. 1, the core foundation is that your power lies in preparation, organization, and documentation. These override the fear of the medical maze. You don't need to be a doctor. 2, the hook is Rachel's story, showing compelling real-world proof that bringing organized data guides doctors effectively and significantly reduces your own anxiety. 3, the promise is twofold immediate confidence and clarity from the current appointment, plus a clear bridge to Chapter 6, which focuses on the proactive what now of daily life and lifestyle adjustments. 4, the single most important takeaway is that mantra. You don't have to control the system, you just need the right tools to guide your loved one through it. And those tools are defined by that crucial 4-point practical toolkit we broke down. The 1-page summary, the vetted questions, the specialist research, and the rigorous logistics prep.
The toolkit is key.
And finally, 5. Our initial critique is that Chapter 5 is highly successful precisely because its structured, checklist-driven, actionable style makes it an exceptionally effective and genuinely empowering guide for caregivers facing this specific, high-stakes challenge.
Well summarized. And if I could leave you, the learner, with one final thought directly from the essence of this chapter, remember that your diligence, your careful vigilance, and especially your documented observations of that symptom journal, they are truly the single most valuable pieces of evidence you can possibly bring to any medical professional in this situation. If you arrive organized, having used the tools we discussed, you literally cannot fail in that appointment's goal. You will simply advance the process to the necessary next step, whether that's a referral, a specific test, more monitoring, or even a preliminary diagnosis. Your organization guarantees forward motion.
That's incredibly empowering. The tools we've detailed today from Chapter 5, they're all designed to help you guide that crucial clinical conversation to make sure you walk out with the actionable answers and the clear plan you desperately need. So now that you have a roadmap for securing that clinical clarity, perhaps the immediate question you should be asking yourself tonight is this. Okay, assuming I get a diagnosis or at least a clearer picture and a plan, what are maybe the top 3 non-medical adjustments I could start thinking about making, maybe even today, to enhance my loved one's daily happiness, stability, and overall quality of life?
Shifting to the proactive, supportive side.
Exactly. That proactive shift, starting to think about things like tailored nutrition, finding the right kind of physical activity, exploring customized cognitive stimulation, simplifying routines, that's precisely the territory Chapter 6 is waiting to help us dive into next time.
So that's your homework, essentially. Start brainstorming those immediate, non-medical ways you can uplift and protect, regardless of what the doctors say next.
Indeed it is. We'll explore how to implement those ideas in our next deep dive. Thanks for joining us.